I'd like to welcome everyone to our July quarterly board meeting of the State Board of Health. I'm very pleased to see our members here on your journey to the state, and I appreciate your service to our state. Also appreciate our honored guests who are here, which will be talking to us a little bit later. But Chairman Creekmore and Chairman Bryan, thank you all for being here. I'd like to begin by asking everyone to stand, and I'd like Dr. Cheney to introduce the individual who will be giving our opening prayer, and then after the prayer we'll do a pledge of allegiance.
Thank you. I'd like to introduce Stan Buckley, a good friend of mine, who will open our meeting with prayer. Stan is the founder and the executive director of Let God Ministries that has done great work in places like Haiti and also in the Mississippi Delta, and is an organization that has allowed people to have hope in those people who need it most. And so,
thank you, Dr. Cheney. Let's pray. Father, we come to you now. Thank you for these men and women around these tables. I thank you for their dedication to our state and to the people of our state of Mississippi. Lord, I pray that you would give them direction and wisdom to make good and wise decisions for the people of our state. I pray for Dr. Edney and his leadership. I pray for Pat now as he comes to be chairman of this group, that you would give him the wisdom and the direction that he needs to make good decisions so that all can have the health care that is needed here in our state of Mississippi. We love you. We thank you that you loved us first. And I pray in Jesus' name, amen.
Amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. The first action is approval of the minutes of the April 8th, 2026 board meeting. Are there any corrections to be made in those minutes? If not, is there a motion to approve the minutes? All in favor, say aye. Aye. All right. Now we're going to the report of the nominations committee. Beth.
The nomination committee has met at length, and we unanimously recommend Dr. Pat Cheney for chairman and Dr. John Davis for vice chairman. They will serve 1 year as soon as we approve it. And I motion to approve them as our state officer.
All right. In her motion, this is coming from a committee, so it does not need a second. If it's the will of this board, we're going to accept that as a slate. So the vote is for Dr. Pat Cheney as chair and Dr. John Davis as vice chair. That is a motion. Is there any further discussion?
I would like to say that, as Beth says, it's a one-year position, but our usual is for it to last for 3 years.
And there is a 3-year term.
Right.
Correct. All right. If no further discussion or recommendations, all in favor say aye.
Aye.
Any opposed? All right, Dr. Cheney.
all right. But before I do that, I would like to, before we move on to today's business, I just want to recognize Dr. Lampton. For the past 3 years, Luke has led this board with dedication, and he's been a steady force, thoughtful, and he's always focused on what's best for the health of Mississippians. Anybody that's served alongside him knows he leads by example, he does his homework, he listens before he speaks, and treats every member of the board with respect. I personally learned a great deal watching how he runs a meeting He keeps us on task without cutting off good discussion. And Mississippi's public health system is stronger today because of his time as chair. And I know I speak for the whole board when I say we're grateful for his service and glad he will still be serving with us. So please join me in thanking Dr. Lampton for his leadership.
And I just want to say I appreciate the privilege of serving with such an outstanding board and a group of individuals. And I welcome passing the baton over to Pat. And I also know that the most important position is not the chair, but the board member. All right, the board member is the one who makes the motions and leads this board. So I'm looking forward to sitting out there and being among the dangerous board members and allowing Pat to herd the cats.
And Luke, the board really wanted to do something to honor your leadership. Unfortunately, we really could not come up with a good idea. So I do want to, but I improvised, and I think I've come up with something that would be really good. So actually, I bought myself a copy of Luke's book, Images in Mississippi Medicine. Now, this is not a gift to you. This is an opportunity for, if you would sign this copy. And might I suggest that you say something like, to my favorite board member, or something like that. Actually, now, I love the book, and it is a gift from me to myself. But the board did want to do something to honor you, and we are giving from the board members a donation to the Mississippi Public Health Trust in your
All
honor.
right. Yes.
Yeah.
Thank you. I couldn't believe it.
You're not going to write on it now. I'm going to write on it.
Absolutely.
All right, Dr. Cheney, come on over here, I think would be the thing to do, or you can stay there and I can pass this over there. What do y'all think?
Yeah, let's do that. I've got all this.
You look like you're entrenched.
Yeah, I might forget.
Yeah.
Okay. Oh, so here we are. Well, thank you. I appreciate the confidence, although ill-guided, that let me chair this, and I really appreciate it. Let's move on to our business. So the state health officer's report.
Thank you, Mr. Chairman. And I look forward to working closely with you over the next year. You may not look forward to it, but the relationship between the state health officer and the board chairs is a strong working relationship, and I've always been grateful. Dr. Waits was chair when I was hired and helped me get to that first year, and Dr. Lampton, these 3 years together. The conversations we've had have helped you make better decisions. I appreciate your wisdom throughout these last 3 years. I'm really grateful. Thank you. And Dr. Cheney, I look forward to our working together, sir. So, as you have given a gift to the Public Health Trust, just to let you know, the trust is fully enacted, and I think you will be happy to know that the first official gift, private gift to the trust was in memory of Dr. Elaine Anthony, which I think was a very appropriate initial gift to the trust. And we've had strong support of the legislature for the trust, and I look forward to showing you the growth of the trust very quickly over these first few years. So having said that, should you be in need of a memorial gift at any point, the Public Health Trust is always one to remember. First, we'll talk about the things, July 1st, we've been working to enact the legislative directives coming our way. These were all CON changes that actually occurred upon passage. We've been operationalizing these as we're moving forward. You're aware, that the changes that were in the first CON bill that doubled the capital expense limits for CON holders, and some changes with the academic exemption for UMC. Those have been operationalized and are before you in your regulatory action. But I did want to just line out for you, because you'll be acting on this in the regulatory section. The Small Community Hospital Pilot Program has generated a great deal of interest among our small rural hospitals, and I've had a lot of really exciting conversations with the ideas that small rural hospitals have, and actually, if you're in the Delta Public Health Region, then you get 2 exemptions. All the other counties that qualify, and we have the eligibility there for you, basically a county but no municipality over 15,000, then you get 1 exemption. And some of the most interesting conversations I've had have been with rural hospitals outside the Delta, trying to decide on which exemption they want to ask for. So that just shows a lot of interest. The feedback I'm getting from the hospital CEOs is very positive. They're really grateful for this. So all this information has gone out to the hospitals. We have given our first exemption already to small hospital, but I think this legislation is going to be definitely very impactful. And the pilot project goes through June 30th of 2027, but I'm hoping we'll be able to demonstrate to legislative leadership that the pilot is successful, and perhaps look at broadening based on Board of Health recommendations.
What was the exemption that was given out?
To Beecham Hospital in Magnolia,
For what?
to convert to acute psych. JIRA psych was granted in the legislation, so hospitals don't have to require an exemption for that. But Beecham was wanting to do acute psych in full, which would have required a CON, and they used their exemption there. Okay, and next slide. And we, basically the process, the only thing they have to do with us is file or request for an exemption, and then we just determine their eligibility. And then as they develop their project, they supply the information to us so that we can incorporate that to the state health plan data and keep up with it. But, a very simple process, and one that will flow fairly quickly. Also, want to make sure you are aware that the legislation instructed us to give 2 CONs per public health region for a total of 8 statewide for outpatient dialysis. And that it's not a first come, first serve, because there's some requirements in the statute for us to give consideration to hospitals that are further away from current dialysis units, but there's a lot of interest in these exemptions as well. So we have not had any applications, but we expect those to be coming in fairly quickly. We're going to wait 45 days before we issue the first one. We want to give all the hospitals an opportunity to file, but it's not going to be based on who files first, but who within those first 45 days has the proper application that gets the highest priority. And then I'm not expecting that there'll be 8 awards by that period. And we'll just go forward as we get applications to analyze them and see if they qualify for the exemption. Yes, sir.
Do you anticipate that there'll be more than 2 per district?
I honestly, Dr. Davis, I don't know. I've had a conversation with one hospital that what they were trying to determine, because it does qualify, they have to use one of their exemptions. So if you're a rural hospital asking for dialysis, then you only have one exemption, then that is your exemption if you get it. If you don't get the dialysis unit, you still have your exemption. But I had one hospital talking through with me. They had, they were looking at whether to look for an MRI exemption or dialysis exemption. And of course, it's up to them, but I just talked through the process with them, and just so to help them make the decision. They would have loved to have had 2 exhibitors, but, they were proud of the one.
Is there and this may have federal rule implications, is there the possibility of utilization of an outpatient dialysis unit by an inpatient in a small rural community hospital to allow patients who otherwise can be treated locally to avoid having to be transferred to a larger hospital that has inpatient dialysis?
Yes, sir. And as you know, the inpatient dialysis is part of acute care, CON, but the problem is the finances. Running an inpatient unit without an outpatient unit. Some of our hospitals do that. But there's several of the smaller rural hospitals really have, their desire for an outpatient unit was so that they could develop the inpatient unit as well and keep those admissions, because it is really frustrating for them to have to transfer up a pneumonia patient whose dialysis has been stable. They just need to continue their chronic prescription, and they could easily be treated in a rural community setting, but they haven't transferred for dialysis access. So, yes, all those conversations are ongoing.
So can a patient that's admitted as an inpatient for pneumonia be dialyzed at an outpatient dialysis center that is physically on the campus of the hospital?
Great question. They cannot, because it's different. It's the difference between like inpatient surgery and outpatient surgery. And the outpatient unit billing, can't be concomitant with inpatient billing. So if the hospital were billing inpatient based on their DRG, CMS would consider dialysis as part of that DRG. They would get a bump with it, but it is an opportunity for rural hospitals that have excess building capacity that they could do their outpatient absolutely on campus and facilities they have and just segregate it, outpatient versus inpatient.
Even in the same part of the hospital, as long as it's segregated between the two.
So it would look like just like an ambulatory surgery center that's be connected to the hospital.
Still functionally, potentially have the same benefit.
Yes, sir. I think so.
That's important. Yeah, that's
So
good news. Thank you.
Thus far, all the feedback's really encouraging. Yes, sir, Dr. Weeks.
It may be covered in a little bit what you were just saying, but what is the CMS condition of coverage for EMDR?
We're just making it clear to the hospitals that what we're doing with CON has nothing to do with CMS regulations or requirements. So that's between them and CMS. Some of the psychiatric units, there might be a CMS issue, but we're just granting the ability to do it, and they have to work with CMS in terms of being a qualified provider. Any other questions? Hey, Austin? I do want to bring this up, and Dr. Dodson's going to be presenting an EPI report, which will impact on this a bit. We do have counties, and they're outlined for you here, where the vaccination rates for kindergartners has gotten below threshold for community immunity. That we still have strong community immunity level statewide, and even these counties where the kindergarten rate has dropped, the overall childhood vaccination rates are still above the 95% threshold. But what we're doing, I want you to know, basically we're at a point, if next year it'll be kindergartners and first graders, and then it'll be kindergartners, first graders, and second graders in these counties. On this trajectory, recurrence of measles really is inevitable, and we're working proactively to prepare for that. We're working with the school districts, especially in the counties who are sub-threshold, and then we have just as many who are approaching threshold. And we're working with the Office of School Health and the Department of Education. We have training sessions with the school nurses, North, Central, and South, that are occurring over the next couple of months, and I'm going to engage with the school nurses with this training that we'll be doing. We're going to be doing vaccination events in counties as much as we can outside of the county health departments. And, you know, Chairman Creekmore, we're doing a vaccination event in Union County very soon that we did last year that was very successful. And we're going to do that again. But when I look at, you know, we have counties as low as, you know, George County, that's below 92%. And the further below 95% we go, then the higher the risk of, and measles will be the most sensitive indicator of a recurrence of vaccine preventable illness. I do want to point out to you that the highest rate of vaccination statewide is in the Mississippi Delta. And those rates are holding strong in our Delta community. So we'll continue with our vaccine advocacy, working to improve access, working with the school districts who've not had to worry about measles since 1992, and just make sure that we're prepared. Alabama had their first case last year. Georgia has had sporadic cases over the last 2 to 3 years. Nothing, all those cases were quickly contained, and we're just preparing ourselves. I'm really proud our epidemiology department has been leading tabletop exercises just so that, when measles is identified, that we're able to work to protect that child and the children in that community. Any questions?
So, Dr. Eddy, you guys are going to the health departments and the school nurses and all of that kind of stuff and making a push there. Is there any opportunity to partner with some of the commercial insurers or private insurers as well? So they're getting at the patients themselves and the parents themselves. So y'all are doing all you can from a public health perspective, but can we engage some, I don't know, employers in that area or
Yes.
other groups so it's a concerted effort? Because this is really upsetting,
It
how
is.
far our rates have fallen.
And when you look at the counties who are approaching threshold and those who are already below threshold, then you see pretty good little map gaps that are occurring. Still, again, the whole community immunity is strong. But, we're not raising the alarm, we're just raising awareness that if school districts who are in these counties just need to be aware, make sure, their response plans, are up to date. And we're also educating providers, because I have to remind y'all, our providers in Mississippi have not seen a case of measles since 1992. So it's not the first thing people are thinking about when a child comes in with fever and rash. And we're just having to kind of re-educate, our providers. When you see fever and rash, you need to think about it.
And I would say that, the big issue is not so much the patient, but dealing with the parents. We see this in the emergency department, where, parents are pretty staunch in their opposition. In fact, we had one probably about a week ago. They came in, they were very upfront, they were anti-vax, but there was a wound that had just occurred that they wanted to take this immunoglobulin for. Not the vaccine, the globulin, in case something were to happen. And, then you had to go through the explanation. But there are all these kind of strange ideas that are out there, and I don't know where that idea even came from. But how do you, I think the thing we have to really wrestle with is how we target the parents to change their mindset. Because, I feel like I'm talking to a brick wall when I try, no matter how tactful you try to be.
Well, our best hope is through our pediatrician and family medicine docs. They're the most effective in providing the proper education. And what's interesting, out of our total number of religious exemptions, 15% have gone on to vaccinate. So, we always refer, talk to your doctor, your provider, and make the right decision, for your child and your family. You know, the big saying for me now is, you know, parents know the children better than anyone, and asking questions are what good parents do. Just ask your doctor and not Facebook.
Yeah.
You know, get your information from trusted, reliable sources, and then we're here to help any way that we can.
Maybe we could even direct it to the obstetricians, so that the moms-to-be are educated before they get to that time to make a decision.
Sure. And I think, I know that Medicaid, managed care organizations are good partners with this. You know, they have a strong vested interest to improve vaccination rates, to, you know, it reduces Medicaid cost. You know,
Yeah.
and so it's, you know, important partnerships. Yes, sir.
So this is data for a complete certificate, which I presume means that you have all of the immunizations, correct? So
This
that,
data is based off completed immunizations.
meaning that for all the different immunizations that are heretofore have been required, of which there's more than one. So do we have, is there more granular data on, are there certain immunizations that people are saying, I'll take that,
But not that.
but not that?
Yeah. MMR is probably, y'all can correct me, but MMR probably is the least adopted, which, you know, is driving these rates.
So the vaccine for measles, which was not derived from an aborted fetus, where I could see a religious tie to. So that one, people are saying in a greater rate, have a religious objection to taking a vaccine that George Washington's army used.
Yeah.
I wonder if they use
Yeah.
religious exemption as like a,
It's
Cover, right?
not, it's not
It's a-
really, for most people, I think there's
Yeah.
absolutely no
yeah.
religious connotation. I'm just kind of curious if can we get more granular data in terms of
Absolutely.
which ones, is it an across the board thing? Or is it, I'll take this, I won't take this, I will take polio, I won't take measles? You know, can we?
We certainly can, and Dr. Johnson may have, you know, some of that information, because she has to deal with all the religious exemptions. But as you know, our process, you know, allows them, you know, to opt out
Sure.
in a selected fashion. And then, and I'm really pleased, and we're actually redoing our messaging for the video that has to be watched. You know, I've got feedback from county health departments that, you know, the process changed minds, you know, and they didn't complete the exemption process. So learning, you know, we're still on the learning curve with it, but seeing 15% go ahead and complete the vaccinations that had already been awarded an exemption is promising. We are having to make sure our primary care docs know that religious exemption is not legally binding, that, you know, parents can reverse it or opt not to use it. So they can get the exemption and go to their doctor later and go ahead and get vaccinated. There's no problem with that. The exemption doesn't preclude doctors being able to do that.
It's also kind of on that same line of more granular data, what's being taken, what's not.
Sure.
How much of it is a timing one? I mean, I know there's a good number of parents, but we were like this, that don't want to take it all at the same time, maybe spread it out, what have you, and it bleeds into when you start kindergarten. If there's a way to get a little bit more specific by
We'll be happy.
disease, would be helpful.
Because I'll be honest, what really worries me, I mean, measles, you know, no pun intended, it's nothing to sneeze at itself. But,
That was really bad. I want to work on that one.
but it's nothing like polio.
Yeah.
You know, the risk of not vaccinating against polio or tetanus or diphtheria, I mean, those tend to be deadly, you know, straight up. And Australia is going through a diphtheria epidemic right now. The last thing we want to see, you know, is diphtheria making a comeback. But, you know, we see some rays of hope. we're really proud of the relationship that we have with pediatricians and family medicine docs in the state, and, you know, we'll keep working in partnership with everybody. The new event that we're doing this year, you know, we have a big back-to-school event at Vital Records, because oftentimes parents need to get a birth certificate for whatever reason, and they're getting their 121 forms for vaccinations. But we're having a vaccine event at Vital Records on the back-to-school days. So if they're coming in and they haven't gotten them yet, then they just get vaccinated, you know, right there at Vital Records. And we're going to have a clinic set up to make it easier on the parents to go ahead and complete their vaccines.
Well, you know how there for a while, we had those billboards of like pictures of syphilis and stuff like that. Maybe we need some billboards of pictures of kids with measles, and like just to drive the point home of it's not a nothing thing. And I think that's the issue with a lot of parents. They're like, it's not a big deal. I had chickenpox as a child, so what? It's fine if my kid doesn't get vaccinated for chickenpox. And it's like, kind of a big deal. Y'all are doing excellent work, though.
Next.
I should say that Washington's Army, I think, used the smallpox vaccine, not measles, but same theory. So.
And he mandated it.
Yeah.
Just to finish out, some other good news. Y'all know the early intervention program has been a program historically that has struggled for over a decade. It's been moved all over in state government. I am very proud that over the last 2 years, the early intervention team, you know, working with the contract support that we've been able to bring in, has really improved our relationship with OSEP, which is a federal partner, and you know, and their evaluations have continued to improve. So finally, early intervention is getting their legs under them in a way that program can be strong, robust, and healthy, understanding the very, very, very limited state support that program gives. But Mr. Perry, if you remember, there was the oddball contract on the last report that Horn for janitorial for whatever, that was.
Our accountants who are doing janitorial services.
That was the early intervention contract. And that contract is really paying nice dividends. Having that technical expertise, working with our team and working with OSEP has paid really, really nice dividends for our early intervention program and the 0 to 3 babies that we serve. It is important to know the Rural Health Transformation Grant Program is a big responsibility for us. Right now, very importantly, for your information, one of the lead items of the governor's application was a statewide health assessment that, you know, we've all been working towards getting done, and now is actually happening as already. So that contract has been awarded, and a comprehensive statewide health assessment is in the works. That will help the Rural Transformation Grant Program work, but it's going to help our work as we reinvent the state health plan. And they understand that was part of the deliverable. The assessment is, you know, to inform our work in terms of state health-wide policy. And you know, so that is something that the Board of Health has been wanting, you know, for the last 4 years, that we're finally having funding to do and making it happen as we speak. The governor's office has released 3 current projects that have been assigned to us. The first project is building rural infrastructure for delivery, growth, and efficiency. It's called the Bridge Project. It's an opportunity, especially for rural hospitals, but other rural providers qualify as well. But they can get capital expense money to work on facilities and expand programs in rural areas, to start new programs that currently don't exist, and be able to invest in infrastructure that they need. The second project is Health Technology Advancement and Modernization, which is big investment in health IT infrastructure and cybersecurity for rural providers. And then the third bucket is the telehealth adoption and provider support, which there's a lot of interest from our smaller rural hospitals. And as another opportunity, Dr. Davis, to keep those admissions, local by using the telehealth specialty support. And this is an opportunity for those hospitals to get funding to build those programs out and hopefully keep those admissions closer to home. So those have all been assigned to us, and we have to score the applications and make the awards. Chris, is it August 15th?
The application's closed July the 15th.
And then, but we have to make the awards August 15th?
Yes.
Yes, so the applications are open for a little bit longer, and then we have to score them and make the awards by August 15th. So that's about $80 million that'll go straight out to rural providers. No vendors, straight out to providers. So that, excited to see that. It is, I'm having flashbacks from ARPA PTSD, from our ARPA projects. So here, but this is, very meaningful work. And I did want to point out to y'all, in terms of measles at the national level, last year we had 2,288 cases nationwide. We're already over 2,100 nationwide for measles. So this 2026 will be the worst year that we've had since we had achieved elimination status. And we're monitoring those rates closely. I also want to quickly mention that you may have read in the news about the cryptosporidia outbreak that's occurring nationwide. That's right now in 18 states. There's over 1,000 cases. This is, largely a gastrointestinal infection that comes from food products and mostly from salads. And so we don't have any cases in Mississippi. We're monitoring it. There are cases in Louisiana, which make me nervous. The FDA and CDC have not identified the source yet, but over 1,000 cases in those 18 states. Last outbreak was in 2018, and it, of all things, was connected to basil from Mexico. So we're just asking everybody, as you're preparing salads, other raw vegetables, just really wash them thoroughly, and that should protect you. Just be aware of it. And
Is this primarily in the immunosuppressed population, or no?
Yes, sir.
It can,
It's all comers. Of course, Dr. Davis, how dangerous it is in compromised patients. But these are also healthy patients, getting it. If you just get enough of a spore load, it'll get you. And of course, there's 1,000+ cases we know about. We don't know how many cases are out there. But it is concerning, the breadth of the number of states, and that we don't have an identified source yet. So all the states work with the CDC on that issue.
It's a good thing you don't eat salad.
All right, Dr. Dawson.
Good morning. All right, so as Dr. Edney has alluded, that measles is the talk of the U.S. right now with more than 2,000 cases already in 2026. However, that is not the case for Mississippi. Our public health threat is an old but formidable foe that we've known for a while and it's staying around, and that is pertussis. If you see this slide, it shows our pertussis cases here in Mississippi. If you look at it, we started having an uptick in 2024. It was also happening nationwide at the same time. But in 2024, we had 49 cases. We didn't get too excited about that because it looked very similar to 2019 when we had 54 cases. But then if you look into 2025, we jumped up to 146 cases. And then we also had one pediatric death in September of 2025. For 2026, we are already at 37 pertussis cases. Hopefully, we will not reach that 146 high that we did last year, but but we're well on our way. And to highlight some of the points that Dr. Edney has made previously about this. So since January 1, we've had 37 cases. And of those 37 cases, when you look at their, they all occurred, and the majority of them, 27 of them, which is 73% of the cases, occurred in those who were less than 18 years of age. And then of the 34 cases with a known vaccination status, 12 of those cases, which accounted for 35% of the cases, so well over 1/3 of the cases, were not vaccinated. And the reasons for not being vaccinated were 5 were due to parental refusal, 1 was due to religious exemption, and 3 were less than 7 months of age, so they're not eligible to receive a vaccine for that. But if we break down the refusals, particularly the 5 parental refusals, because I had to ask the staff myself, well, what's the difference between a parental refusal and a religious exemption? Well, a religious exemption occurs when you have to get that Form 121 that we saw so that the child can enter school. But of the 5 who were parental refusals, those were children who were less than school age, who would not have required a 121 form, but the parents made the choice to not receive the vaccine. So that highlights a good bit of what, this is in graphs of what Dr. Edney has previously discussed with us.
So a majority of the people who have now protested were vaccinated.
Yes.
So,
So you do have though, if you look at those, you'll see some that were older, but also that you get waning immunity after a time. So a lot of those, where we've seen the most outbreaks have been in middle school. And that's right in the time when they start to get the booster shot. So if you get them somewhere in between the time, between the booster shot, where their immunity has waned to the point where they're no longer fully immunized, that's where we've seen the most activity, and that's where we've done most of our outbreaks this past year. I will say that our team did an excellent job of getting into those school systems, identifying contacts, offering PEP, which is prophylactic medications afterwards, to get people treated. And so we were able to keep children in school. We were able to keep them in there, upping our reading scores and our educational scores, because we were able to keep them within the schools, not having to shut anything down, but we were able to reach those. And so our epidemiology team and our 9 nurses out in the field did an excellent job of reaching all of those contacts and making sure that we got people treated and kept other citizens safe.
so I just kind of wonder, is this based upon your experience, is this statistically significant data? I mean, like it's still pretty small numbers. Am I wrong? If you go back to the previous page, I mean, the spikes are severe, but the y-axis is really low. I mean, obviously, 2007, there's a big difference between hanging out around 50 plus or minus and going up to close to 300. But is this, what is,
What accounts for the difference?
well, like, what's the number that like says, wow, this is a problem versus did we just have a bad year?
I think one death says that we have a problem there. I also think you have to account for the fact that we do very robust work and identifying contacts and providing PEP so that we don't create large outbreaks, so that we don't have any more infections. So I think it's a combination of the two, that we've gotten better with contact tracing and early intervention there, and a whole lot of preventive work. So I think it's a twofold effect here. But I do think these are significant numbers
okay.
for us.
Ms. Perry, to your point, you look historically at pertussis, we were never able to eradicate pertussis like we have every, mumps, measles, diphtheria, polio. Those vaccines are just so much more effective than the pertussis component. So it's, and that waning immunity is a thing. And we've even looked at, do we need to move, is it the 7th grade dose?
The 11-year-old.
To a little earlier or not. But basically, even with waning immunity, it gives them a lot of protection against severe illness. So it's, but, to your point, our job is to keep those numbers down and look historically how the comparison. And we'll keep tracking this for y'all. Pertussis is not it's the vaccine preventable illness that drives the bus, but it thankfully it's not overwhelming us. And it takes a lot of energy from Dr. Dotson's team, to keep those individual cases from becoming outbreaks. And so, and that's with, the levels of vaccination that we have. It really, worries me, 15 years from now, we may be having South Carolina type outbreaks, if our numbers statewide are getting too low. But, just keeping the Board of Health updated on the pertussis issue, we'll keep tracking it.
And that kind of goes to the question I had on the vaccine chart, like how much of the not being in compliance was DTaP?
It's increasing, but another set of, since we're getting into the granular data, you see 146 cases here, but our team identified over 1,100 contacts and people, and we offered PEP to over 800 people. So those could have been potential cases had intervention not happened there. So it's, like I said, it was a twofold variable here in that we were able to do better contact tracing and to reach more people. So even though we had 146 cases, the number of people that we actually touched was over 1,100.
And that, with the DTaP, what worries me is the diphtheria and tetanus component. Those are opportunities, once the child has it, we've lost, the way you take care of children is not to give the diphtheria and tetanus. So pertussis is more manageable, but as the DTaP numbers drop, and tetanus is all out there. It's throughout our soil. All you have to do is talk to the veterinarians and how many tetanus cases they treat with horses and cows. And the same will be true for us. Mentioned that, I'm sorry.
Why I think I've heard somebody talk about this. Why the spike in '07?
We had an outbreak.
Contact tracing wasn't as good as it is now.
We got a lot better at a lot of things. It's so sad.
You mentioned the West Nile.
West Nile. We've had our first human case of West Nile down in the Southern District this year. We had 33 cases last year, and we've had a total of 10 hits in mosquito beds where we actually test for West Nile. So hopefully we won't make the 33 this year.
And I'm really proud of Dr. Johnson's EPI team and Teresa Wyndham's emergency response team. We worry about Ebola so you don't have to. But we had, to activate our Ebola response, we had 22 travelers back from the DRC that had to be monitored, and they were not in the high-risk areas, but now all the DRC is high risk. But, they had to work with and monitor 22 travelers coming home and did a great job. Everybody did fine, had great cooperation from the travelers. And Teresa Wyndham's team, had to stay in the field hospital, up. And the thing that we fear the most is a traveler coming home that we don't know about who goes to the ER with flu-like symptoms as Ebola. So we have to be prepared. We can't wait till the case is identified. We have to be ready should a case be identified. But we've gotten through the surveillance period for the travelers. And right now, Dr. Johnson, we don't have any.
Actually, before I walked in here, I got an email with an update from one CDP as of the end of business day early this morning that we have an additional 12 Ebola travelers that we will have to monitor here.
Great.
And this week, but they're all not high risk to use
Okay.
the CDC's term.
Yeah.
So the 22 have completed their surveillance, but now our total of people we will have surveilled will be 34 once this last wave comes through.
So just whenever there are Ebola or Marburg outbreaks in Africa, then the states have to be prepared because of travelers. And so what we always have to do when there's a declared outbreak, travelers are coming home, we have to stand up an isolation unit, which we use the field hospital out of the airport warehouse. And then EPI surveys the travelers for symptoms. And should a traveler become symptomatic, then we have to get them into isolation and get them tested. And then we actually have to transport in a secure fashion the sample to Atlanta to be tested. God forbid if it's positive, then we have to transfer that patient, that Ebola patient, from our isolation unit through very specific emergency transport. High-level isolation in that emergency transport. We have contracts in place to do that, but we transport the patient halfway to Atlanta. Emory sends the unit to meet us, and we would exchange. So every time there's an outbreak in Africa, we have to get this system in place. But thankfully, this is my second go-round with this. We had Ebola outbreak in 2022, and I was fresh on the job, so this is our second go-round.
May I reiterate one point here, and that is Ebola is a class 1A reportable disease. So that means it has to be reported to a person here at the central office. So we encourage you to call the number, report it to the EPI department, and then we will take care of the rest. No need to start any kind of process on your part. One call, that's all. Hate to use somebody else's tagline. But it's in public domain, so we'll borrow it today. But one call to us here, it has to be reported to a live person, not an email box and not a voicemail box, but to a person, so that immediately once we get the call, we're on the clock and the clock starts rolling. And that's the case for any class 1A reportable disease, whether it's rabies or pertussis or measles, any of those diseases. One call to us, and then we will take care of the rest. As Dr. Edney explained just now, it is a very kind of complex system that we have to navigate, but we have a plan in place, and we're here to protect you. And so just, if you suspect it, just give us a call.
And we'll be in this mode. Ebola outbreaks typically run 6 to 8 months, can go up to 12 months. As long as the outbreak is still ongoing in Africa, then we'll be, our readiness will be at a high level here. Things that we do with the health department people just don't realize. All right, thank you. Dr. Johnson, you saw all the scaffolding outside as you came in. I was so proud to see that this week. That is the work on the public health lab envelope that building bureaus have been working with us the last 4 years, and finally there's a contractor in place to get that done, which will seal the public health lab the way it was engineered to be sealed. The exhaust fans are, how close, Laura?
It's supposed to get the repairs done next week.
Next week. And so hopefully, as soon as the exhaust fans are repaired, then we can generate negative pressure in the public health lab again. So everything moving in the right direction. I'm so grateful to see that scaffolding out there. Any questions? Mr. Chairman?
Completion of that project estimated?
What contractors say 2 weeks. But we'll see, to be determined.
Money.
Any questions? All right, thank y'all. Mr. Yoon?
morning, I just wanted to briefly mention that, during this time of the year, we are going through a closeout of one fiscal year, and we're starting the new fiscal year. So the finance team is in the process of closing out fiscal year 2026. We will, once that process is complete, we'll be able to present our financial performance for 2026 to you all. Also during this time, the team is working hard to prepare the fiscal year 28 budget request for the agency, which is due next month. So there are a lot of reporting pieces, closeout pieces, and budget pieces that we are maneuvering through at this time. As Dr. Edney mentioned, gave a brief update on construction projects. Yes, we're glad to see the scaffolding going up, being up at the lab, and the work is starting and being done. We did have one project that was finished up, and that was out in Pearl, the ARPA medical countermeasure warehouse is completed. So again, we do have multiple projects, capital improvement projects that we're working on for the Central Campus, and we will update you along the way. Are there any questions or concerns?
Next item is getting the budget prepared for LVO by August 3rd. So that's a lot of activity. You know, they're having to close out as they're also preparing the budget year. That's budget year 28, correct? The state year 28. So a lot of good work going on. The new pharmacy space, we call it the box in the back. It literally right now is just 4 walls and a ceiling. That completes out phase 1A of the renovation work, completing the interior to make it the public health pharmacy warehouse and offices is in phase 1B. So hopefully that'll be happening, work starting first quarter 27, we hope, don't we?
Yes.
So we're anxious to get that space operational. Any questions? Okay, thank you, Mr. Chairman.
Okay, next item on our agenda, board regulatory actions consent agenda. We've had a chance to read over that. Are there any items to be extracted for further discussion from the consent agenda?
Motion to approve the consent agenda.
Dr. Lampton made the motion to approve. Dr. Carlton seconded. All in favor, say aye. Aye. All opposed by the same. Okay. Committee reports.
And I don't know if any committee reports.
The only thing, EMS has not met, but we really fortunately haven't had a need to. I would like to throw a few roses at Teresa Wyndham for the work that she has done, as well as everybody else in the office. And just so that you know, the consent agenda, 4 of those items dealt with EMS, but they were addressing issues that we've talked about previously regarding manpower and recruiting and retention. One of the problems that we've had that these changes took care of was there was one of them moved us in line more with what's going on nationally regarding age of drivers and who could actually get certified. You know, we began as an effort to try to increase the number of people entering EMS by offering courses in high school, and they could take those courses, but then they couldn't become registered because of their age. And so one of these regulations changes that and eliminates the age requirement of 18. So now when they complete the course in high school, they can become registered. So that's going to be a huge help to us, and hopefully we can help continue to retain those people and help them advance to paramedics and that sort of thing. And then the other one was, we had a major issue with EMS to enter into, particularly being into paramedic training, a requirement that you had to have A&P in advance. This now changes the requirement from, you can do it prior, or you can do it concurrently with the training. And that way, they don't have to spend a year or so in a community college with additional expense and time to get there. So hopefully this will help our manpower issue. But those are the kind of things that are going on behind the scene and why we really haven't had to meet, just FYI.
One question on the, with the development of the OB system of care. I don't know if this is the right time to ask, but will that strain the EMS system, or is it gonna help? Is it gonna hurt? Is it gonna, what?
Oh,
That's a
absolutely it
huge
will.
piece
To
of
answer
puzzle.
your question, absolutely it will, but there are some other things being worked on within within Teresa's office to try to help mitigate some of that. Obviously, where we've got the greatest concerns, what the greatest need is, and that's in the Mississippi Delta. But there are plans being developed. We're not quite ready to roll them out yet, I don't think. But yeah, I mean, just like trauma, STEMI, stroke have strained the system, OB is certainly going to, but I think we can have some solutions to present to you.
Well, unintended
Well,
consequences.
but also, Dr. Carlton, it's straining our legacy system.
Yes.
And what Dr. Carlton's talking about is, modernizing the EMS system itself more to the regional approach where assets are more available. A lot of work going into that space, to your point. And if y'all remember, this was 2 years ago, that it was one of my concerns that EMS itself was struggling from a capacity standpoint statewide, and we were looking at bringing on a fourth statewide system of care down the road a bit. So a lot of our legislative work has been raising awareness at the Capitol, and which have been responsive.
And that's excellent. Again, to Dr. Edney's point, regionalization is going to help tremendously. Currently, we've got a system that's county by county, and that's not the way referral patterns work. There are some solutions that, but like everything else, it takes a little money and organization and commitment. But I think it's more doable now than it would have been a few years ago.
I totally agree. Yes, sir.
Okay. OB, maternal leave.
Yes, sir. So, piggybacking off of that, just to give you a quick update on OB system of care, that work is moving along nicely. We're expecting our first in-hospital surveys to occur next month if we're able to stay on track. All the advisory groups are in place and functioning. Performance improvement groups are organizing. I keep emphasizing performance improvement is really what's going to help drive the reductions in maternal infant negative outcomes as we study those more robustly. A couple things I'm really proud about. We've been participating in a locate program with the CDC, as long as I've been state health officer, which has been a survey of delivering hospitals and querying them in terms of their capacities and looking at what their neonatal capabilities are, and then kind of letting them rate themselves as to what level of birthing hospital or neonatal care they were, which was showing about a 40% error rate in a bad way. And we would get maybe a third of the hospitals would respond. This year, 100% of the birthing hospitals and NICUs responded. And it was a very favorable exercise, and the team worked, Teresa's team, Dr. Randy Henderson, all worked together to get the survey the way it needed to be for the hospitals. And now we have a baseline for all the hospitals to compare their self-attestation with the survey, and just as we do with the trauma hospitals. So really good work going on. I also want to point out that a amount of national attention we're getting is really amazing. I think we've had 3 different states reach out to us who are trying to go down this road, watching what we're doing and seeing how we're doing it and actually trying to ask us how we're doing it. And it's been really encouraging. I know Arkansas is watching closely what we're doing because they really want to try to do the same thing. So, a lot of good positive coming out of that. And not ready to share the infant mortality numbers from last year. We are closing out the year, and we'll still have some death certificates that are coming in that can affect it. But as of today, we are seeing a significant reduction in overall infant mortality compared to 2024. So very encouraging, a substantial reduction. And the data that you were seeing in the media in the last couple of weeks was the 2024 data. So it's going to be well below 9, it looks like. So we were 9.7 last year. And once we close it out and we know, because just a few deaths that aren't counted yet could impact the rate. So, but I just want to give you that encouragement that all the work everybody's doing at all levels throughout the state is making a positive impact.
Any other committee reports? Chairman Bryan and Chairman Creekmore, we would love to have you all make some comments, and the floor would be open. I know that's dangerous.
I'm just happy to be here. I think Sam and I come because you're supposed to play chess with people who know more about chess than you do, so you can learn something. I think it's the same principle. Speaking for myself, all I did was win an election. I mean, I don't know anything about public health, but it's very helpful to me to come and listen to y'all and have ongoing conversations with you. It's very helpful. Those of you on this board and your predecessor for decades have done a very good job. Staff here, currently and for decades, has done a very good job. People are attracted to competence. People are attracted to places where they can feel they're doing something important and fulfilling. One of the things that happened to me after I got this job is I observed the dramatically different cultures as you go from agency to agency and state government. The State Department of Health didn't get here overnight. Thank you for the work you do maintaining it so we can keep that going. Thank you.
Well put, Sam.
Mr. Chairman, along the infant mortality issues, one thing we've been doing through the public health emergency is really studying what are all of our options. What are other states doing? And what is the evidence pointing us to do? And out of the top 7 recommended forms of intervention, we're doing 6 of them. But I want y'all to know, working with Chairman Creekmore and Chairman Bryan, we're looking at all the options. What do we need to be doing to save our moms and babies? Which I know is the desire for all of us. And I'm encouraged at the level of work that we're doing. The evidence is showing there's more work to do. And we will continue to vet that information for you as we consider all of our options.
Dr. Waits.
in regard to what Dr. Edney was just talking about, I've had some reading in the last several days about what several states are doing on their maternal and infant care. And they're having some remarkable results in various places. And I want our board to follow up on that and have a conversation on that at some point.
Certainly, certainly. See where the data leads. And thank you all for the work that you do. We do appreciate it.
Where's Logan? Logan, did you write down when Chairman Bryan said, I don't know anything about public health? That's why you keep us around.
So, nothing else on committee reports, any new business? Any old business?
One question for you, how do we get into how do we give money to the trust? Is it on our website easily? Or?
It will be. We're building a portal for the trust, working through our website. But today, you can give me a check.
Made out to the Mississippi State Health Department.
We notified when the portal's open.
Yes, sir.
Very good. Okay, all right. I would like to entertain a motion to consider going into executive session. Mr. Hubbard and Dr. Carlton, seconds.
And this is for a personnel and litigation matter?
Yes, for personnel and litigation matter. All in favor? All opposed? Okay, so the board has voted to close the meeting, so the board may go into executive session. Anyone other than board members, Dr. Edney, Chris Adcock, and Kristen Williams may now be excused while the board considers this motion, this The board in executive session, the board discussed a personnel matter related to the job performance of persons holding specific positions at Mississippi State Department of Health. And may I now entertain a motion to adjourn?
Move.
Second.
Second.
All in
Aye.
favor? We're adjourned.
Thank y'all.